All right, so now we're going to be getting into the drug allergy side of it. So let's hop right in. It's going to be a pretty similar lecture to the food allergies in structure, but the thing with drug allergies is I'm going to spend a lot more time talking about their mechanisms or various proposed mechanisms of how drug allergies work because they're distinct in many ways from food allergies. And I think that's really interesting. So I just want to start off by sort of highlighting the importance of all of this, which is, if you ever want to go work in healthcare, drug allergies are going to be something you run into multiple times a day because you have to ask every single patient. And even if you don't want to go into healthcare, it's worth knowing why every single medical provider is going to ask you about drug allergies. So that's sort of the background foundation that I want to lie here is that this is something that's really going to saturate and infuse every aspect of healthcare, whether you're a provider or a patient. So drug allergies could be seen as more of the colloquial name, whereas you might formally call them adverse drug reactions or ADRs. And these basically describe any bad effects, so noxious, unintended, undesired effects that are occurring at standard doses that we would expect to help someone. So we can divide these ADRs into type A and type B. So type A is considered on target. This is basically when the side effect is predictable and dose dependent and also related to the main pharmacological action of the drug. So, as an example, you can see that in this picture over here, warfarin causes bleeding. And this has to do with how the intended mechanism of warfarin works. It's just that this is a sort of known side effect. This is something that's going to happen that is undesired but also related to what it's supposed to be doing. So that's a pretty adjacent function. So this accounts for around 80% of adverse drug reactions, and also includes things like drug interactions as well with other drugs. Now, type B is the one we're going to be talking a little bit more of today. So this is obviously the rest. This is the remaining 20%. And these are considered off-target, or in other words, these are unrelated to the pharmacological actions of the drug. And so, these include drug allergy because drug allergies are obviously not related to the actual receptor that they're supposed to be hitting. And this is what we'll spend most of today focused on. So just a quick sort of epidemiology overview. Some of this data is actually kind of hard to obtain because there's not great studies on this from what I could find. But if you're interested in the prevalence, we could say maybe around 15% of inpatients and outpatients have a drug reaction, whereas a little less than 7% of those are serious and less than 1% of those are actually fatal. And the most common drug allergy, as many of you will know, is penicillin. So around 10% of the general population reports a penicillin allergy. However, the really, really interesting thing is that if you were to test 90% of these individuals, or if you were to test all of them, I should say, 90% of them would not actually have a true allergy. And there's many reasons for that. Some of them have outgrown it. Some of them were very improperly diagnosed when testing was not as rigorous. And this has a pretty big cost on mortality when people need penicillin for certain complications, but they have to take other things. It has a cost on the quality of care, what we're able to give as providers. It has a very big economic cost as well because having to go your entire life avoiding one of our frontline antibiotics is obviously not great. So that's also something I want us to keep in mind is just that, this will come up again in the sort of diagnostic section at the end, but how do we actually find out if someone has a drug allergy is a question that we should be asking. So there are three models for how a drug allergy actually works. So these are not sort of like competing models necessarily. These could coexist, and there are things that there are certain drugs that fall more into one and certain drugs that fall into more of another. But I'm going to go over all three because this is very distinct from food allergy, where food allergy, especially IgE-mediated food allergy, is sort of just like, it binds to IgE goes through this whole signal transduction cascade through the mast cell, leads to granulation, blah, blah, blah. But this is different. So that's the first thing I want to just give is that this is nothing like food allergies. So let's get into the first one. So the first model is called the hapten-prohapten model, and you might not know what the word hapten means, but we could define it as a small molecule which can covalently bind and alter a larger protein. Um, so this model is most commonly associated with penicillin. So this is a really important one to know because again, this is penicillin is such a prevalent allergy. And this is, I'll go over a little bit how it works. So basically, as the definition suggests, the drug is going to act as a hapten molecule. It's going to bind to a peptide, and it's going to form a novel tertiary structure. We can call that tertiary structure a neoantigen because it's comprised of a sort of drug and a peptide, and it's forming this unique structure. And that unique structure is the actual structure that elicits the immune response. So if we look at penicillin over here, there is something called the beta-lactam ring. So it's this ring on the left here. That ring is pretty tight, and because it's tight, it's going to be very unstable. That's your organic chemistry if you know any of it. And because it's unstable, it's going to want to break open that ring. And it's going to very readily react with lysine residues in other proteins. And when it does that, it's going to form this penicilloyl determinant by binding to this protein, which forming the neoantigen. And that neoantigen is going to be, it has that penicilloyl epitope that can be recognized by T cell receptors. So, penicillin right here can break down into these sort of, subcomponents. Those subcomponents act as hapten molecules, and those haptens bind to peptides to form a neoantigen, and that neoantigen is what your body is quote unquote allergic to. Now, the second model is the pharmacologic interaction, or P-I model. So this model basically says that instead of binding covalently, the drug is going to bind non-covalently, and instead of acting only on the TCR, it's going to bind either to human leukocyte antigen or major histocompatibility proteins, or TCRs. And so you can see that's you can see that in the image over here that you could be acting on either receptor. And basically what this does is that it works mostly for drugs that are more inert and don't readily react with proteins or peptides like the penicillin molecule does. And by binding to these receptors, you can essentially prime them to elicit a T cell response. So sort of similar, but different in that it's non-covalent. I would say that's sort of the big function here, or the big difference here. So what's the evidence for this one? Well, we have these experiments called APC fixing experiments, where basically you take an antigen presenting cell, APC, and you remove its ability to process an antigen. So whereas the hapten-prohapten model sort of relied on some sort of processing, we can see that in this case, you can still have a drug elicit an allergic reaction without any sort of antigen processing, which means that it's not actually being sort of ingested by the cell, it's sort of modifying the receptor externally. And more evidence for that is that when we culture T cells and drugs without a peptide, so no ability to form that neoantigen, we can still see an immunologic response that is sort of dose dependent. So pretty strong evidence that this model exists in some cases. Now the final one, this one is a little less known. This is called the altered peptide repertoire model. So this one also is non-covalently, and it binds specifically in the HLA binding cleft. And this causes basically chemical changes that are going to change the reactivity of the HLA receptors. By changing that reactivity, these receptors are able to sort of overreact to certain things that are, should be standard and not dangerous, just like a normal food allergy. This sort of lowered threshold of hypersensitivity is also really present in, or it can be co-stimulated by viral infections as well. So I want to get into one just really quick drug allergy case, or ADR case. So this is called SJS10, or Stevens-Johnson syndrome, and toxic epidermal necrolysis. So historically, these have sort of been considered distinct pathologies, which is why, one has this name, SJS, and the other one has its own name, 10. But nowadays, as with many sort of conditions, they're being more understood on a sort of spectrum with, SJS being sort of the less severe one, and then 10 being the more severe one. So, what happens in this? Well, clinically, you have extreme blistering. You have necrosis of the epidermis, and that's going to occur around various mucous membranes. It's going to occur on the skin, the eyes. So very painful. You can see in the images down there. And most of these cases are drug induced, specifically via medications like anticonvulsants and sulfa antibiotics. So if you ever hear about someone asking about sulfa allergies, this is probably what they're asking for. So just a quick mechanism on what happens. Well, the drug is going to be interacting with the HLA molecule on keratinocytes. So first of all, we should probably understand that this is not the Hapton model. It's maybe the pharmacological interaction model, maybe the altered peptide model. But it's going to interact with those keratinocytes, and it's going to cause them to present and activate that drug to T killer cells in the epidermis. And these are going to release a massive wave of granulysin, which is a protein that is going to cause all of these sort of symptoms. Let's talk a little bit how we're actually going to diagnose this. So I want to talk first about skin tests and just use penicillin as the sort of example here because of how common it is. So again, this is the most common skin test for drug allergies that you'll see. They'll be for penicillin. So how it works is penicillin is going to very rarely exist as penicillin. It's going to break down very readily into two components, which are penicilloyl, which is the major component, and then you have the minor components, which are penicilloate and penyloate. So what we really care about is that penicilloyl. So if you have, we'll inject both of these into the, intradermally, and if the patient has a reaction to either the major or the minor determinants, they're going to be considered positive for a penicillin allergy. And if they're negative for both of these, but they still have a reaction, well, you are going to test directly for R groups. So if you look at the penicillin molecule on the left here, you can see that has the R group. So if you're not familiar with organic chemistry, the rest of this molecule could be considered sort of the backbone or the penicillin backbone. But the R group, depending on what that group is, it could be a different class, such as an amoxicillin. So again, if they're not reactive to any of the penicillin compounds, but they have a history, then they might be reactive to amoxicillin or some other related family. So that's sort of the line of logic that I want to bring up of how you might go about skin testing for this. Just to see, like, again, the drug allergy tests are a little more intricate and involved than perhaps an environmental allergy. And finally, drug challenges are going to be a gold standard, just like in food allergy. The only way to really know if you don't have or have an allergy is to take the substance. However, unlike food allergies, these are only really used when the patient is going to be unlikely to be allergic and they really need it to be taken off of their record. And so that is going to come after the skin tests have already come up negative, after if it's been a long time since they had the reaction, etc. And you can also test for sort of immediate reactions by giving fractional doses and just building up, or delayed reactions. Sorry, I got that mixed up. The fractional dose is a small dose, and if they're asymptomatic, then you just jump to the full dose. But if you want to test for delayed reactions, you do graded drug challenges and gradually go up the ladder over the course of multiple hours. So anyways, that's a quick crash course on drug allergies, and I hope you learned something.